for the people who are on this part of the continent, and good morning who are on the western side of the continent. We quarterly of something which is of the interest related to healthcare innovation, sometime from Indian people, and we have requested Chris Lloyd, who is the Vice President of Simpler, and also many of the projects together in India, Singapore, Malaysia. He is the Vice President of Simpler, which is in turn has been taken over IBM. I have great regard. Not only that, I have learned a lot from him onto the lean side. Now, as you are aware, this would be there to explain to you. Lean and innovation are two sides of the coin, which I have written in a number of articles. Of the hospital itself, which we have done in one of the hospitals in India, which Chris has also seen in Iris Hospital, where operational. Ultimately, as you know, the lean is a Toyota system, and that is the one which says 90% waste can be reduced, 60% to 70%. Well, there the whole dimension is how healthcare, reduction of the cost. Keep myself between you and the Chris. Chris will make a presentation, and after that you question to the Chris, who would answer, and in the last I'll sum up. I have my team of the people and Alok, who are there always assisting me all these the webinars. So accepting our invitation and to be part of it. After that, of course, I'll separately chit chat with you as well as Sachin. Thanks, Sachin. Over to Sachin. Thanks, Chris, and over to the Chris.
Very proud to be able to share some thoughts and ideas with so many great colleagues. What I'd like to talk about is actually one of the chapters in Dr. Singh's book on innovations in healthcare management, and in fact, it's very difficult conditions. So you'll actually get a chance to see a little bit more of the graphical side than was possible. And, we've worked together in many parts of the world. My association with the incredible innovation of with IBM, I'm currently involved in the IUIH, so that's the Indo-UK Institute for Healthcare, between the British government and Mr. Modi in India to develop new health facilities in India, and the first one is in the UK, but actually almost to be the test bed for really advancing new healthcare. So this is something I'm still involved in with you all in India. Thank you. So the topics, excuse me, sorry, I'm just trying to advance the slideshow. There we go. Sorry, through some number of issues. The presentation is with Dr. Singh and with Sachin, so I'm very happy for them to get one. So I want to talk a little bit about some of the design principles that we've become very familiar with, talk about what we call the voice of the patient, and then developing what we call waste-free, so only adding value to what happened in the models, and then design the new facilities around those most efficient methods, and of course simply to ensure that the new ways of working are very much effective, and then again completing the designs and infrastructures as we go forward. So these are some of the topics I'm going to cover as we work our way through. And one of the reasons I think it's so important, to have a goal, and the mission is not to be lean. It's not to who is the former chief executive of the American IHI and really is a global healthcare innovator, as better than we've ever seen, to have health better than we've ever known, cost we can all afford for every person every time in the world, and therefore it's our duty to be able to develop that capability. So how can we use our improvement capability? What we have is effectively 5 steps towards creating complete new models of care, creating new health boxes. I'm going to elaborate and take you through greater details, but we'll start with defining the customer or the patient's wants, and in design they are two very different subjects, and mixing the two can be quite wasteful, and with creating an operational model. So not the design for the health facility, but actually what should the pathway to provide the right treatment for the patient populations that we have. And then, having understood that, and by flow we mean there is no avoidable waiting for the patient, whether it be waiting for in the ED department for a specialist outpatient clinic consultation. In all cases, we wanted to create the services. So how are we going to actually undertake them? How would they work in the physical environment, in the health flow of the patients, so that their experience is very good. There is no distraction to the staff from people getting lost, trying in a safe and affordable, effective way. And there are actually some very good examples in India already of how they went several years ago, and they developed some of their clinics to really create the best way of getting the full cost so that it is affordable for all. And then finally, having got the new processes and the systems, so that the architects and the hospital planners can create the blueprint for the future. And when we develop new health facilities in this manner, we can actually take out nearly 50% of the design entirely reduced. And whenever I talk to architects or hospital planners, they are very frustrated because their processes often take, it's not so profitable for them. So actually there's a lot of waste in the process that's affecting not only the patient, but actually in our experience, there is three principal design elements that we always recommend. Is use the knowledge of the doctors, the nurses, the managers, the administrators, who are daily undertaking the care for the patient. The architects and the planners are very important, but actually it starts with getting them. And then what we really want them to do is to be processes that are 100% right each time, that are only adding value to the patient journey, that make the patient journey. And this is very important to develop that before we design the facility. And the other key is in unnecessary undue haste. We actually mean that it's a very rapid process so that we can actually get to the longer period of construction to follow. And we do this because there are some key challenges, unrealistic expectations for the staff, and then they complain about the new building afterwards, or the distraction for the course. There's many examples around the world when new hospitals, new clinics take longer to bring to market, so there's finances, and of course ensure that we have a frozen design. So these are some of the key principles. 20 minutes as we go into that. So I mentioned it starts with defining the patient need, the voice of the patient who's paying for the services, and we really need to understand what it is they need. And a need is a problem, and a problem needs a sense of the need without creating new problems or waste. So in other words, unintended consequences. So thinking about the timely interventions, do not create a problem somewhere else in the process. To understand the patient's Kano model, which is very established, and that's on the bottom graph there, and that has three elements of basics of most complaints about any service. So within healthcare, that we would expect a basic requirement or limb, that the medication given is the correct medication in the correct dosage. They're all very things. Patients that have any failure in those areas often get I'm sure we all know, a bad reputation. The performer time from referral to the first appointment in the outpatient clinic. Have you been given an indication of how long? These are all very things that are almost specified, and something we can manage. And then the third element, which off-rider, is what we call the delight, and it's unspoken. And they're often not a luxury. They're sometimes perhaps in the level of information they're given. Perhaps it's because they never expected to have a conversation with the surgeon operating on there that are very important to them. And that creates differentiators, so that when you're in a private hospital situation, as much of India is, now the Kano is quite a simple model, and once we've got the inputs from the Kano, a detailed specification, and we use a tool called quality functional deployment, and that's a very well-known design, and explore and expand, and we use a ranking scoring method to actually work out from what the patients told us. Clearly we can't do everything that somebody says they actually need, so it's important to differentiate between what is really important. So understanding the patient needs means we can now focus on developing and ensuring that we have pathways over that care to the patients. So the next step is actually, as we're starting to design the pathways, is the frequency with which we have to be able to provide a service to avoid delays and queues, and this is developed originally by Focke-Wulf in the Netherlands many years ago. Beat or the pace of the aspiration. So, for example, if we're talking about ED, in a very busy time in ED, we did every 5 minutes. That becomes what we call the Tack Time. If we don't treat them within 5 minutes, then the queue is static. So the idea of using the Tack Time is to be able to calculate the rate at which we need to sing the basic arithmetic of how much available time do we have. So in this case, it's saying 8 hours in a session, how many patients, and therefore it tells us that the rate at which we have to take care of the patients. And we can use this to then calculate the resources through the process, but to ensure that we have the number of cubicles, the number of payment points, the number of chairs in the waiting room, and where demand has an internal influence that we could change. So for example, the time, a lot of x-rays, not to schedule that at the same time where the data tells us that we have a lot of people bring an immediate x-ray. So we can take out some of the spikes in our demand by understanding the understand the rate of the patient flow. We can then start to design our health system around providing the care. Everyone to use is, they often call them a Manhattan chart, the black columns at the bottom of the chart there are. So this is looking at in England what we call a minor injuries facility, where patients are walking in with cuts and attention, and literally what we're trying to do is balance the time that it takes to undertake the act, etc., and ensure that that time does not exceed the rate of the patient arrival. Remember, we call this the Tack Time. Queues will not fall. If they peak above them, the queue will form, and then we start to build stress into our system. And this is the kind of model. I just did this on an Excel file. You don't need any software. You just need to understand the Tack Time calculation, and then using the treatment time, you can calculate the resources required to avoid any queuing beginning. So it's quite a simple but effective method to go. Once we understand the pace of demand and the pace of treatment that we need, we can then start to ensure that our pathways have the value-adding steps in and have a method of eliminating the steps that are not helping the patient to get through their treatment. So we call it a process preparation, or a 2P model. And at the very top is the patient journey, the different stages they're going through for the particular pathway that they're involved. But then what we also identify is what are the skills from the staff required to undertake that stage. And the Americans call this operating at the top of the license. So this means that our clinicians can be really involved in the highest level of their competence in diagnosis and treatment plan formulation. We can use our nurses to the highest level of their training, and similarly the ancillaries and the other staff. So this means that we can actually get much more patient-facing time from the clinical experts. And we similarly identify what we require at each step of the process, in the equipment, in any materials, surgical or whatever supplies, the information that may be required, the quality management process. So whether you're NABH or Joint Commission. Again, what are the things that we must control during that process, and then also any specifics about the location. So are we dealing with the risk of an infectious disease? Do we need to have that part of the facility with controlled airflows? So and we'll do this for all of the different pathways that will go through, the patient types that will go through the new healthcare facility. And in the small photograph, you may not be able to see it very well, but literally it's stickies on a piece of paper, because it's a very collaborative process to involve the staff in doing that, and then we digitize the output afterwards. And then when we've got those processes and we understand the rates of flow, then we can start to work on the building. And we have that in two steps. We call it the macro and the micro. The macro is literally using multiple ideas and ways of locating services within the new building. And often the new building shape is already determined. It's how to function the departments within there, to locate the departments within there. And again, we're just using big blown up diagrams, and then literally using the stickies, using the approach to try and start to work out that methodology. And then we can start to identify adjacencies that will help us optimize the patient journey, where services should be located, the direction of travel so that there is less congestion, particularly separating patients with significant problems from the general public walking through the health facility, so that there's more privacy and care designed from that point of view. And then also starting to understand what services should be on each floor, using the patient information, the tack time, best practice and ideas, multiple ideas of how we could construct and develop the floor. And the bottom right-hand diagram is for what they call an integrated building in Singapore, which is the transition between acute care and follow-on care for patients leaving the hospital. And then we can produce a much more detailed design of the layout and the construct. And we're doing this consistently with the stakeholders, with the staff, the doctors, the nurses, the managers, the planners, the designers. If there is a significant governmental input, as in the case of the Singapore photographs, the Ministry of Health, all working in these workshops to develop this future view. We also then, when we think we have the right structure and the right process, we want to test it. And ideally it would be with a computerized model, but actually that's often creates a long delay in the process. So we developed a methodology of actually using a people-based simulation, almost like a child's card game, board game, where, and in this example was for an infectious disease hospital, we literally created spaces on flip chart pages for the different functions and departments, the number of beds we thought we needed, etc. And then we ran through multiple scenarios of arrival of patients with unknown diseases, unknown pathogens, and we used that to find the point at which our design would break. And over 3 hours, with the staff actually fulfilling the roles they do in the real life work that they do, we were able to find out the breaking points and then design and update the design to have solutions for those breaking points. And once we did that, we then take it a further stage and actually try and do a number of full-scale three-dimensional testing. And that is literally finding a space, sometimes even a car park, and mocking up the area. And if it's trolleys that are moving through, putting the trolleys through that, and then we find that with the full size modeling, if you will, real life modeling, we find snags that would not be visible on even a sophisticated computerized modeling. And also the staff get an idea to feel how the process would work, and therefore they become champions of that process as well. So that's quite important. So before we get into really detailed design with the planners and the architects, we've tested our idea to see whether it's feasible. And that's very important, because in many of the projects I've been involved in, the planners and the architects often complain that the design is changing all the time. There's a new idea. So we're trying to make sure that we can have freeze points where everybody from the hospital leadership and owners down to the clinical leaders and the staff have actually had the chance to sign off that process, sign off that design, because then they will own that and they will take that forward. And if we do that with those freeze points, it usually shortens the design period considerably, because we're not having to retrofit and rework our designs. And again, we go back to our models, our Tack Time models, with what we learned from the simulation, to ensure that we are still creating the position where the work task is not taking longer than the rate of the patient flow through the system. So ultimately, we're going from the developed concept, which is still a big picture with sticky notes on, to a visualization for approval. So this is at the point where it starts to look like the future design, and then into drawings for scale, and then ultimately into visualization for communication. So whether it be 3D simulated models, designed graphics, but it starts to create a much better way then of sharing what the future health facility is going to look like, and to engage a wider level of stakeholders in the process. And another aspect throughout the whole process, which we find when it's applied has very significant results in improving the quality of the outcomes and shortening the end-to-end time, the lead time to produce the design, is to use really effective, we would call them world-class design management principles. So for example, I'm sure many people know Toyota bring new designs to market in a quarter of the time of many of their competitors, because they've developed that design process that meets the customer's needs, is very inclusive, but gets it right the first time through that. And that's through really 4 phases of the project management, from the pre-planning and the program planning, which is when we're coming up with the concept designs, doing the Tack Time study, and then the detailed design is when we're really getting the architects and the designers to convert those ideas and those pictures into the working model, when it becomes very much, and then finally production or the implementation of those processes. And to manage that throughout the course of the project, there are key elements. For example, decision flow. So a lot of design projects are very much based on making decisions to proceed with a certain feature. So by designing the flow model for decisions, starting with the endpoint of when we need to have completed our design and approved it, back through the process, we actually get a much more optimal process of decision making that's required. So we very much then know when do we have to have a decision about that attribute of the design to enable that project to be completed on time. And we also use, we would call them lean, but we also use collaborative stakeholder project management methods, that I think called the vertical value stream. This literally provides input into conventional project management like Gantt charts and Microsoft projects, but by understanding the collaboration required between multiple stakeholders, which, for example, designing a new hospital critically has, and that gives us the pace of progress of the project that we need to manage. We also really encourage, for the state of the project, to have what we call the big room, the Japanese call it the obeya, the collaborative design space, which has all of the key information around the walls and on boards, from the decision flow that I mentioned before, the vertical value stream, the project plan, team communication, key decisions that are made visible, cost trackers, problem solving tools like failure mode effect analysis and root cause analysis, design statements, and then also utilizing that space for the workshops with the staff, so that there's a very collaborative working space. And if you look particularly at things like software design, for example, you see more and more large rooms of a lot of young people with these visually managed working environments, collaborating on designing the latest app. And my own company, IBM, actually has their design studio set up in exactly the same way to develop the latest health app that they want to develop. So having that very structured project management methodology means that there's less distraction for the leadership of the organization. It's clear when they have to make the critical decisions on the design and the process of the design, and the communication is very simple because it's extremely visual within that large room, that project team environment. And just a couple of examples, and because of confidentiality in Singapore, I can't show the photographs, but some examples in North America where we've used the same process. Atrius Health they have about 14 ambulatory care clinics in the Boston area, northeast of the US. One of their facilities was very dilapidated. It was basically almost an industrial building. They desperately needed to improve the facility, and the whole process that we managed with them enabled them to close the old facility on the Friday afternoon, and on the Monday morning the patients were being served in fully quality approved pathways and facilities, but literally 2 days later. And some of the key benefits is they're actually $3 million under budget, which they'd never achieved in their projects before in the past. They finished a month ahead of schedule. They actually had managed to design it in 30% of the footprint, less of the footprint than their other facilities of a similar type, and had real operational efficiency improvements. So for in their day case surgery, their end-to-end time for their operating rooms was halved, and in some of their walk-in facilities, a significant reduction in some of the equipment needs. So a very positive outcome for them to as a consequence of their new design. In another facility in North America, very much not just a new clinic building, but also completely new medical models being designed for particularly high-risk patient care requirements, and a lot of very significant quality indicators to be improved. And within that project, in various elements, they got between a 30 and a 50% reduction in the end-to-end lead time. The client's needs were all met, and actually the number of hours spent on the project were between 20 and 40% less than the similar projects that had undertaken in the past. And ultimately, it was very smooth because of decision points and freezes. There were significantly less reworks and updates required from that point of view. So I'd just like to recap on some of the key principles that we found are the most effective methodology, and that's to begin with, always begin with the voice of the customer or the patient, but make sure you differentiate between the needs and the wants. Fulfilling the wants are often not sustainable and often not solving the problem. And I mentioned at the beginning that often this is about solving a problem for a patient. An illness or a deficiency is a problem to be solved. And then ensure that we start with patient flow within the design principles. The shortest end-to-end pathway produces the safest, best value patient experience if it is designed along a qualitative base as we go forward. And it makes healthcare much more affordable as we go forward, because ultimately, why should a patient pay for the waste in the design that creates a blockage in the flow? And then also, of course, we say form follows function. Design the optimum flow process, and then the facility can be designed around that to deliver that service. And of course, the engagement of all of the staff, the doctors, the nurses, the managers, the leaders, because then they will be the champions of the new ways of working, and that will lead to that 48-hour transfer of one building to the next in the most positive way. And then finally, I think it's very important to note that leadership provides the vision, but we've found the staff provide the details. So we actually have to give them the environment with which they can provide those details. And really this picture is just a collage of steps in the end-to-end journey from the idea of the need for the new building or the updated building through to commissioning it for receiving its first patient, so that revenue is being generated as quickly as possible after the investment, and basic using very good simple techniques of involvement, engagement, testing, patient flow, and patient focus. Ultimately, we believe gives us our greatest advantage of our new facility. So I'd really like to thank everyone for joining the webinar. As I've mentioned, Dr. Singh has a copy of the presentation, which I'm happy to be shared. But of course, if anybody has any other questions outside of the webinar, my email address is there. So Dr. Singh, I think I'm within a few minutes of the scheduled time, and we're hopefully ready for questions. Hello?
Yeah. Thank you very much, Chris, for your time and a lovely presentation you have already made. I already have two questions which I'll be asking you on behalf of the participants. However, in the meantime, I request the participant, if they have any question, that they can send the questions, and I will be asking the Chris to reply. The first question is given that who should be project team leader, lean expert, hospital planner, or an architect? Over to Chris.
Thank you, Dr. Singh. That's, as always,
Yes,
you always lead with the most difficult question. I think it's a very good point. Our experience is that usually the client commissioning probably still wants the architect to be the leader. So in many of the projects that I've undertaken in Singapore, we were actually appointed by the architect, but under the understanding we're working in collaboration in a clean way. So probably the architect is the team leader, but it's a very collaborative approach where we're working towards the same goal. But usually the commissioning through the architect is the preference for many clients.
Yeah, thank you. The second question is, how lean concept can be sunk into minds of promoter, planner, or architect that it reduces the operational cost, because experience has been they're still not convinced that lean concept can be utilized by them for the hospital designing and planning purpose.
Thank you, Dr. Singh. That's another great question. I think, you know, as you well know, Dr. Singh, the heart of lean is the voice of the customer or the voice of the patient. And as I mentioned in the presentation, our patients shouldn't have to pay for waste in the system, you know, particularly if it's waste that we can eliminate. So, you know, for me, the way to convince it is we want our patients to get the right treatment in the right place at the right time. So that's from a provider perspective, but from a payer perspective, the patients want to actually have good value for money, so not paying for the waste. And in our experience, the only way to bring the two requirements together is to eliminate waste in this processes and then in the way we've designed the health facility. So if we can actually bring those two points together, we should have actually the best possible outcome. And the other thing I would urge of healthcare owners and leaders of healthcare is this is a potentially great competitive advantage for you to provide the best healthcare at an affordable cost, but with a good profit margin, because at the end of the day it is a business and the investments have to be recovered. So I think if we meet the needs of the patient in the most cost-effective way, and that value-based approach, we often call it value-based care, we know has the lean improvement at the heart of it, then this is the way to take that forward, and not just to be lean, but to provide patient care in the most accessible way at the right price.
Okay. Yeah, the other questions are, what should key points should be focused more while designing an emergency wing? Whose opinion in this case matters more?
Great question. Thank you. I've been very fortunate to be involved in a lot of emergency bay design work, because often we all know that the demand can appear to be very unpredictable, and we get very significant variations in the rate of patient arrival. And in my own country, in England, anybody who's visited will know, unfortunately, that Friday night and Saturday night is probably 4 times the patient arrival than any other time of the day or the week, because of, unfortunately, alcohol abuse. But so we know we have unpredictable demand. However, we actually find that when you really analyze the data of patients arriving in emergency departments, it's actually quite predictable. And it can be predictable at different times of the year or different times of the week. It can be predictable based on public transport arrival. So sometimes we even studied the arrival of the bus, because we actually knew when the bus arrived, patients would get off. And this means that we can start to create demand scenarios, and then these tack time scenarios. So we don't have to have 20 different arrival rates. We could possibly find that there's 4 or 5. And Dr. Singh, you might recall the work we did with Dr. Lal in the labs, looking at the different rates during the week of arrival of blood samples for analysis and testing. We can create a number of those things. And that means then we can then design that into the process. So we don't have to have additional resource permanently available for waiting for somebody extra to arrive. We can actually design it to have them available at the right time. And we can make it very visual. So in a hospital in Singapore, the ED specialist had a great idea of literally closing part of the ED department, and only when the seats were fully occupied in the first part did he open the next bay and then the next bay. So actually he could see the rate of progress, and he could call for additional physicians to come to the ED to do the triage and the forecasting. So the answer to the question in that case, Dr. Singh, is we need to get the data and understand that, and then we need to work with the head of ED to design how that is going to approach that. So it should be data driven, but then provided by the experts.
Okay. Yeah. There's another question. What is the upper limit on tack time?
Okay. Tack time can be seconds or weeks or days even. So actually, there almost isn't an answer to that, because on the chart I showed the tack time is the available time divided by the rate of the patient arrival. So ultimately it can't be longer than the opening period of the facility. But again, we can find natural groups of tack time and arrivals and patient flows, and create solutions for those natural groups. So we don't need to have 100 different scenarios. They frequently come down to 3 or 4 from that point of view. I hope I answered that question correctly.
Yeah. Now another question is, when you say voice of patient, now how do you really collect the concern of the patient?
And there are multiple ways. There can be focus groups, which are more complicated to organize. we have often, with permission, we've often visited the outpatient clinic waiting room, we've visited the ED department waiting room, and with agreement of the patients, we've talked to them about what is happening with them and capturing that. So if you think about that Kano model, we didn't ask them to create the Kano model, but we asked the questions which enabled us to create that model. And we would do that at varying times in the day. So for example, recently, one of my team was working on a Sunday evening in a hospital because we'd heard anecdotally that was actually a very busy time, and to come and talk to the patients in another time wouldn't give us the accurate basis. So, and then the other method is just through simple asking 3 questions when the patient arrives and just recording that information. So we can capture a lot of patient information quite quickly.
Fine, thank you, Chris. There are a lot of comments that thank you very much, very illuminating, informative and structured presentation. So I can see half a dozen things are there on appreciating what have been presented by you.
Last question, Professor Venkat, how do you accommodate uncertainty?
Now, the last question. How do you accommodate uncertainty in demand in the healthcare?
Okay, so as I mentioned before, you can actually, the past data is often a very good prediction of the future, and we can build in, of course, aging population, we can build in others, but we can become very sophisticated and even build in weather and climate conditions. So, for example, if we think about seasonality, we know, and we can get from the weather people, certainly in many countries, when the air quality is changing, when the pollen count is high. So we know we're going to have more people with a challenge on respiratory problems, etc. Similarly in a colder climate, when we predict very bad weather to come, we either rain or ice or whatever, we know we're going to get more people into ED. There will be accidents on the road. There'll be people falling over. There'll be people having issues. So we can build up scenarios around those different demand requirements as we go forward. And as I mentioned before, it doesn't mean we have to have exceptionally extra resources to cope, but we have through our scenario planning, we can actually develop our responses as a problem escalates. But as I mentioned before, some of it is predictable, not perfectly, but quite predictable. And as health systems move towards population health management, we find that the population health data can help us become more and more predictable as we go forward. And it doesn't have to be sophisticated to begin with.
Thank you, Chris. The participants, and I think it has been wonderful discussion, and the questions were very taken off. We at the Innovation Curious, that is, we call it a IC, we do take care of the various kinds of healthcare innovation in terms of having a conference, training, which we are recently doing it now on cyber security. And with the Chris, I am also planning that how we can take up this evidence-based, laced, innovative hospital design, which he is expert. And he knows India well because he has conducted number of their training and the consultancy. So if he has time and he agrees, probably we might take up that. We have launched a health club, the Healthcare Innovation Club, which is very well received. And 26th of this month, we are already sent a mail. The deliberation will be how government can fund the various projects and modalities. Somebody from the government side is coming and speaking. We also have a quarterly magazine where you can publish whatever your experiences have been, so people can learn. And in the last, we have this is our second book, where we hospital planning and designing, which has been published by CRC in the USA on 31st of October, is now also available in Amazon India, so within a week. So very relevant to what it is. That, and the next issue of the magazine is also on hospital planning and designing. Basically, you may send your articles. We don't charge any money for publishing an article. It should be acceptable, that's all. And you would find that we want to focus one by one on various issues in the magazine: cybersecurity, hospital planning, healthcare quality, etc. And Chris, I am really grateful to you. He is already our advisor, and I personally indebted to him because I have learned a lot from him. Thank you, viewers, and thank you, Chris. And Chris, anything last word you want to say?
Thank you, Dr. Singh. It's been a pleasure, and you know, I genuinely tell my colleagues every time I come to India, I learn so much, because it's kind of the idea of frugal innovation. And to be frank, the West needs to learn to do that, because I think you all know that the financial crisis in healthcare in the US, in UK, and across Europe is getting worse, because they need to change their mindset. So, you know, I just really would urge you all to keep innovating and keep breaking the mold of paradigms of thinking, because we can learn so much from you taking this way forward. And good luck, Dr. Singh. I'm sure you will lead your country to a great new set of global healthcare principles.
Thank you, Chris, and I'm sure whenever I request you, you will be part of us. That's all. Thank you very much. Great.
Thank you.
Thank you. इसको कल